Good evening, everyone, and welcome to the launch of our Minimal Residual Disease, MRD chapter as part of the Myeloma Crowd Community Program by HealthTree. For those of you who don't know me, my name is Audrey Burton-Bethke, and I am the Myeloma Crowd Community Manager. We're joined tonight by Dr. Natalie Callander, who I will introduce formally in just a moment. I'm going to share some intro slides with you, and then as we finish this up, then I'll turn the time over to Dr. Callander. So I'm grateful for your support, your participation here today. I do want you to know that today's session will be recorded, and this recording is going to be posted on YouTube. We will send you the link along with the slides, my slides that are shared today within 48 hours after the event has concluded. As always, I'd like to thank our sponsors, without whom this would not be possible: Bristol Myers Squibb, Amgen Oncology, Genentech, Adaptive Biotechnology, Sanofi, Oncopeptides, Karyopharm Therapeutics, and Takeda Oncology. So today's topic is what you need to know about MRD, the basics. We wanted to start off this chapter with a little 101 about MRD. Today, we'll talk about questions such as, what is MRD? Why is MRD testing used, and how is it tested? When should this testing take place? And to aid us in learning all of that information, we'll hear from multiple myeloma specialist, Dr. Callander. It's my pleasure to introduce her to you. She joined the section of hematology bone marrow transplant at the University of Wisconsin in October 2004 as an associate professor in the Department of Medicine. Dr. Callander graduated from Tufts University School of Medicine in Boston, Massachusetts, has completed residency at Bellevue Hospital in New York, as well as a hematology-oncology fellowship at the University of California, San Diego. Her board certifications include hematology, internal medicine, and medical oncology. We are so excited for this presentation and to launch this chapter with you, Dr. Callander. The time is now yours.
All right. Well, good evening, everybody, and thanks for the opportunity to talk about this subject, which I think causes a lot of both excitement and confusion as to what we should be doing with minimal residual disease. So I thought I would start off this evening by showing a few slides. I don't want to take up all the time with that, but I just thought it might be good to frame the conversation. And now comes the most terrifying moment, which is whether I can share my screen and show my slides. So let's see if this works. Okay, and Audrey, can we see them?
Yes, we can. That looks good to me.
All right, let me go from the beginning here. Okay, so everybody is going to be coming to this conversation, I think, with different levels of knowledge. So I wanted to make sure that we're all kind of on the same page about some of the terms that we tend to sling around. So MRD stands for minimal residual disease. And basically, you can apply this to lots of different types of cancer, not just myeloma, but it's basically the ability to find abnormal cells within large populations. And so this is a technique that's being used in myeloma, but for that matter, it's being used more and more in leukemia. And there's even some discussion that it may be used as part of treatment for other types of cancer, like lung cancer, for example, or breast cancer. So it's always important that when you're evaluating MRD and when you're talking about it, that you get a sense of how sensitive the test is. And by that, it means what's the ability of this test to detect an abnormal cell. So they often present this with a negative number or negative exponential. So for example, you might see somebody says, well, our test is sensitive to 10 to the -4, meaning that, okay, they can detect an abnormal cell if there is more than 1 in 10,000 and so forth. So right now in myeloma, the bar has been set by the International Myeloma Working Group to try to use tests that are sensitive to at least pick up 1 in 100,000 cells. And many of the tests advertise themselves as perhaps being sensitive to pick up as little as 1 in 1,000,000 cells. So that's something to keep in mind when you're taking a look at some of this, is how sensitive the test is. There's a lot of discussion right now about what's called progression-free survival. That is a clinical endpoint that's used in a lot of myeloma studies. And basically, it means how long are you going to be living without a relapse of your myeloma. And people sometimes talk about progression-free survival 1 and 2. And the second, PFS2, is sometimes used to say, after you relapse from your initial treatment and get a second treatment, how long does the progression-free survival after that last after that second treatment? Overall survival, alive without, but you can be in any state of myeloma as long as you're alive. And then we talk a lot about medians, and basically the median is a midpoint in a collection of data. So half the data is higher than that median point and half is lower. It's often very close to the average amount or the average number, but it's not quite the same thing. But that's used a lot, just so we're clear about that term. So I'm sure everybody or many people have seen a slide like this that is basically used to sort of sub in for what might happen as you get treated for your myeloma. And so basically on the left, we're starting off with smoldering myeloma, and then you get active myeloma enough that we can see it, and then you go into remission. But you know, when you talk about remission, the question comes up right off the bat, well, if it's really remission, then how are you relapsing? Because if you look at remission for other types of cancer, they usually mean that that's going to stick, or that's part of the concept. And as many of you know, remission, in complete remission that is permanent, in other words, cure of myeloma, is still elusive for us. But we are used to seeing this sort of pattern where people go off a therapy, they're okay for a while, they might start another therapy, but they're still getting to a point where it doesn't look like we're able to control myeloma anymore. So the question is that if we change, and this has always historically been determined with things like, can you detect an M protein or something called immunofixation? So can they pick up an abnormal protein with just very sensitive techniques? And historically, if you couldn't do that anymore and those light chain levels were normal, we would call that remission. But clearly, it's not a cure because people can relapse from that situation. So Audrey and I were talking a little bit before we began about this iceberg slide that I'm sure many of you have seen. And basically what it is supposed to represent is that when we're telling a person or treating a person for myeloma, we see this part of it very well, but we're not seeing perhaps what's underneath very well. And you shouldn't walk away from this and thinking like, oh my goodness, I have so much more myeloma that nobody can see, 90% of it is hidden. It's more to say that if you're really thinking you're getting rid of all the myeloma cells, you're probably kidding yourselves with older techniques. And if we have treatments that can make this level of cells present, of these myeloma cells present to an extremely low level, are you going to actually get to a cure? And this is, again, this is theoretical, this isn't actual, so I just want to emphasize that. But some people have hypothesized that in myeloma, since it's really an example of a disease that the immune system is having trouble handling, if we got a person to a low enough level of myeloma cells down here, say, not this kind of maybe what we used to think of as a good treatment, but perhaps a little bit superficial. But if we really, really can get people to a level where their myeloma cell number in the body is very, very low, then maybe that's going to be a low enough level that your immune system can hold off any regrowth of myeloma, and it could essentially be associated with a cure. So right now, and people ask this, right now, all of the MRD testing that is being done is really being done with bone marrow. And we're going to talk a little bit at the end about what's out there using whole blood right now. But suffice it to say, if you walk into your provider's office and say, I want an MRD test, that means we have to do a bone marrow biopsy. And not only do we want to do a bone marrow biopsy if we're going to do an MRD test, you have to have a good one, because we want to make sure that it's not kind of a not a good aspirate, as we call it. And I think for those of you who've had a bone marrow biopsy, one marker of a very good or very well done bone marrow aspirate is it smarts. It actually, you can feel that kind of pull. And that typically means that we are getting a sample from this part of the bone marrow. In other words, we don't want just the superficial layers. We want something sort of deep. And then, of course, at a baseline, we assume that we're going to see some amount of plasma cells shown here. So these are plasma cells, these fried eggs in a bone marrow, and this would be a bone marrow that would look like it's MRD negative, although, of course, you can't determine that by just looking under a microscope. So there are a number of methods around that have actually been around for close to 10 years, really looking at ways to determine MRD in multiple myeloma. And one of the issues has been right now, or one of the issues is right now, is can we agree that one test for MRD is better than another? And there are proponents of the two major methods that we're going to talk about a little bit. ASO stands for allele-specific oligopeptides. This is a technique that's one of the first one that was done. But primarily, when you're talking about MRD with your care team, they're going to be either offering you a test based on flow cytometry over here, or with what's called next generation sequencing. So what's the difference? So when you do flow cytometry, you're taking a fresh liquid sample of bone marrow and you are passing it through a laser after you are mixing this bone marrow with a number of fluorescent antibodies that are supposed to stick to the plasma cells, the abnormal ones, and show you that they're there. So this generally requires, like I said, a fresh specimen. So usually they're done. This is not something that you would typically do on a Friday afternoon. Your physician might have you in on Monday and Thursday, and it is something that tends to be more widely available. So this is something that sometimes non-academic centers have set up. One of the other advantages, and we'll talk about it, is if your myeloma has changed over time, this may be a way to help you get to it. The other very widely accepted method is next generation sequencing. And typically that term is used interchangeably with the clonoSEQ assay or adaptives assay. And this is a test that, now this is relying on plasma cells being there. This test is relying on DNA. So it's relying on nucleic acids that are basically extracted from kind of a mushed up a sample of bone marrow. So that's what it's relying on. And if you're going to do a little bit of a compare and contrast between these two methods, clonoSEQ, as many people know, it is currently FDA approved for use in myeloma. One of the advantages could be if you are a patient and you want to have an MRD test done on this bone marrow, but let's say they can't provide one, you could actually freeze that bone marrow and use a stored sample. So that can be done. Now, one thing that is somewhat difficult to, or people don't realize, for this methodology to be used, you need a comparison. So basically, you need a sample from a time when you had a lot of myeloma around. And most of the time with NGS testing, this means you need to find a sample from when you were initially diagnosed. Now, sometimes labs or sometimes hospitals will store those baseline samples and you can get to them, but it's a little bit, probably in the future we'll be able to take that piece of bone marrow that's usually is kept in the pathology lab and do this kind of sequencing, this next generation sequencing on it. But right now, pretty much we need an aspirate sample, but we also need a bone marrow test from when you were first diagnosed, if that's going to be the comparison. Another advantage of this method is that it doesn't take a lot of aspirate to do this. So if you think, you know, boy, if I'm going to have to get an MR test, somebody's going to want to pull out a gallon of bone marrow from me. They don't need to do that to run this, which is nice. If you look at flow cytometry, now most clinical labs these days will have a flow cytometer available to them because they use it to analyze other types of cells, other types of samples. You don't need a baseline sample to run next generation flow, to do that flow cytometry, because it's based on a staining pattern that is fixed. So again, no baseline needed. There's a little bit of concern that the way the tests were initially developed, that if you are on or have recently received daratumumab, that drug can interfere with some of the analysis, because typically they are looking for cells that are CD38 positive as one of the, what we call cocktails, meaning they'll take a combination of anywhere between 6 to 8 to even up to 12 different antibodies to mix it in with this bone marrow. And CD38 tends to be one of the ones that they use, but often if a person has been on daratumumab, all of those CD38 positive cells are gone. Another issue is the sample has to be fresh, and that can be an issue. So if somebody said, tomorrow, oh boy, I wish I had run flow on this bone marrow, I wish I'd run an MRD test by flow, there can be situations where that sample is just sort of deteriorated and the test can't be done. Some hospitals get worried about reimbursement for this test, as it has not yet been FDA approved specifically for this. And then the other issue is that compared to NGS, compared to the clonoSEQ, you probably need a larger sample. And that's because you're looking for that, you need to look at many, many cells to make sure that you're not finding an abnormal cell. So that requires a fair amount of bone marrow to do that. And again, I'm not talking about gallons, but here you might get away with a 0.5 microliter or milliliters, of bone marrow. Here you often, the pathology lab will like you to have 2 or 3 milliliters at a baseline, maybe even more than that if they have their way. So, okay, so I can, if anybody has some questions right now, I can take a pause there for a second.
Yeah, there's actually a couple, and I think you answered one of them, but they'll be saying that they're having a stem cell transplant in a week, supposed to get MRD results, but they were told they couldn't do the test. I'll just read it out loud so that people can hear. They couldn't get a clone from the first bone marrow biopsy 2 years ago or the one done 9 months ago. And they would have never been able to do an MRD test because the clone has to come from an early bone marrow biopsy.
So you could get a flow test done in this situation. So this would be a very good situation where that would make sense to do that. And I think there have been a few studies doing a comparison between these two methods, because everybody would like to know, is one really better than another? And well done flow cytometry appears to be very similar to NGS, to clonoSEQ, in terms of how sensitive it is. So so we believe that access to either one, now depending on, and I'm going to show you just a little bit about some clinical trials here. Some trials require one versus the other, but I think the situation that was just described, unfortunately, is pretty common. And so people get very worried about it, but you can do a flow cytometry based MRD assay in that situation.
Oh, that's great. That's awesome. Maria's question is about next generation flow versus flow cytometry. When counting cells in flow cytometry, is 1 million the standard?
Yeah, so that's a great question, because I alluded to it a little bit, because there is some debate about how many cells you should count, but part of the issue ends up being is if for some reason the bone marrow aspirate is a crappy specimen, and that's nothing to do with you as a patient. A lot of it's a technical issue. So if for some reason it doesn't have a lot of cells in it, that can be a way where that MRD test might not be as good as you want. And so the number of cells that should be counted, I think there is agreement it should be at least 1 million, depending on the institution you're at. Some people say it's got to be 2 or 3. Most people print or have a range, and I think the pathologists are always more is better. I mean, I think that's what they're going to say. But I think usually we would hope that maybe 1 million could be counted.
Okay, awesome. I think let's move on to the studies,
So,
and then we'll come back to these.
Okay, so what I wanted to do is say, so why do we care about MRD? And this is an older trial that was done for people diagnosed with myeloma and then went on to have a stem cell transplant within a year of diagnosis. And this is an older study that has been published, but presented a couple of times because they ended up including later on a MRD test. So the basic gist of this study was everybody got treatment, whatever they were advised to get. Everybody got a transplant. Some people just got Revlimid maintenance, lenalidomide maintenance. Some people got extra chemotherapy after the transplant, what we would call consolidation, for 4 cycles using bortezomib, Velcade, lenalidomide, and dexamethasone. And some people went on to get a second transplant, and everybody got Revlimid maintenance or lenalidomide maintenance. So what they ended up showing is that the big news at the time, a couple of years ago when this presented, was it didn't look like if you did extra stuff, it made much of a difference in either this progression-free survival or overall survival, whether you had this extra treatment or you had 2 transplants. So if you look from all of these curves, as they call it, are right on top of each other, meaning there's really no difference. But later on, they ended up saying, well, if you have high-risk myeloma, is anything looking a little bit better? And they did feel like in this group, maybe they could show that the double transplant was better. The problem about this analysis was that this wasn't what would be considered really a planned analysis. It was kind of done after the fact. And so they were a little reluctant to say we're sure that that this is going to stand out to be the best. But one of the other things that they did show is if you go back to here and you look at the average survival 5 years, about 76% of people across the board are still doing okay. In this high risk group, that number at 5 years drops to about 44%. So clearly people with high risk myeloma weren't doing as well. And then they looked at MRD tests. And so regardless of which of these 3 treatments you got, if you're looking at your overall survival and you are MRD negative, you did better in terms of your survival. And particularly when they tested it at 1 year after the autologous stem cell transplant. So this was right away, MRD testing, so they saw some differences. But even more striking, if they did this a year later, people who were MRD negative up here were doing quite a bit better. So that has brought up the question that some people may start asking is when do you do this MRD test? And that is something that is under debate right now. This is another analysis of a trial called the French group, IFM 2009, showing much the same thing, and this was a chemo versus transplant trial, or delayed transplant versus chemo trial is another way to say this, showing much the same thing, that this is MRD tested right before these patients went on a year of Revlimid maintenance. And what they ended up showing is even if you didn't get a transplant, if you are MRD negative, you're doing better in terms of your progression-free survival. So again, it looks like using MRD as negativity as a way to determine how somebody is doing or going to do may be valid. So 2 studies are showing that. This is a more recent study called the Griffin Trial, where now people are being asked to have 4 drugs at the beginning when they're first treated. So bortezomib again, lenalidomide again, dexamethasone, but with or without daratumumab. They've got this for 4 cycles, 4 months, and then an autologous stem cell transplant, and then 2 more cycles of the same treatment they were on before the transplant, and then maintenance. In this case, if you had daratumumab, you are getting it again. If you only had lenalidomide, you're staying on that. And they ended up showing that looking at response rates, that if you had the inclusion of daratumumab and you're looking for that remission, basically defined as no proteins present at all in the blood or the urine, that there seemed to be a much higher rate if you had daratumumab when you're looking at 1 year after 1 year of maintenance. This is a pretty good response rate. But the big splash that they presented at the American Society of Hematology this year is looking at MRD negativity rate after 12 months of maintenance. If you got daratumumab, they were showing a very high, now this isn't every patient, but they were showing a very high rate of MRD negativity 1 year after maintenance had started, of about 78% versus only 40% here. So they haven't yet been able to show a survival advantage, and they couldn't show a progression-free survival. But this is where the discussion ends up with many people in the field saying this number is so strikingly different that this is going to translate to better overall survival and better progression-free survival if we wait long enough. But I'm going to refer back to this slide here in a little bit again. So other studies are looking at different designs. This one was a study from Europe called the Forte Trial, where they're trying to see whether just using carfilzomib by itself for 12 cycles would be as good as a transplant. Suffice it to say that it looked initially like that would be true. This is also a study where they asked people to use carfilzomib with lenalidomide or lenalidomide alone as a maintenance, and they shuffled everybody up here. So you had a chance of being randomized after this initial randomization to one of these two types of maintenance. And they showed that if you look at people getting the transplant, which is shown here in this particular box, that the likelihood of having a good response was much better than in this case if you got carfilzomib with cyclophosphamide. When they initially presented the data, it didn't look like there's going to be this big advantage for transplant, but it ended up after more time that this really did pan out, particularly in people who were high risk. But one of the other big deals was the rate of MRD negativity seemed to be better in people who had the transplant. And that was just updated here. So this is people getting carfilzomib, lenalidomide, and dexamethasone, or carfilzomib, Revlimid, and dexamethasone and no transplant, or people getting this carfilzomib and cyclophosphamide. This is looking at a MRD test by flow cytometry, looking for fewer than 1 in 100,000. And again, it looks like transplants adding to MRD negativity. Now, this has been also MRD negativity as being something that we think is associated with better progression-free survival and probably overall survival. This is a non-transplant trial called the MAIA study, where they used, again, daratumumab, lenalidomide, and dexamethasone, or lenalidomide and dexamethasone. And this favored, again, the 3 drugs over the 2 drugs. This is treatment for people who are not getting a transplant. This is continuous therapy. This is not halted, and ended up showing a big advantage for those patients receiving daratumumab with their lenalidomide and dexamethasone. And again, sort of the same theme that you said, seeing these more drugs seems to produce a higher MRD negativity rate. And one of the things that they were able to show in this particular study is that they had people who had sustained MRD negativity. In other words, after checking at either 6 months or a year, that people kept that MRD negativity, and they think that will likely translate again into better survival. This is, I put this up again for completeness sake. This is what's called a meta-analysis. And this is when you take a bunch of different clinical trials and pool all the data together so you can try to see if the hypothesis you have, in this case, being MRD negative, is better regardless of your treatment, no matter what it is. And this is data where they took over 8,000 patients from all sorts of different studies for over 90 studies, put it all together and tried to draw some conclusions. And they basically looked at people who were getting a transplant, people not getting a transplant, and people who had relapsed myeloma who were going on trials. And in every case, they found an advantage in terms of this progression-free survival if you were MRD negative. Now, the time point that the MRD negativity is tested, it's not the same in every trial. So there's a little bit of issue with that, whether it's done right after your treatment finishes or a year later or, 6 months or 2 years later. But again, the trend seems to be there that being MRD negative seems to give you a better progression-free survival. So that leads us to where we are right now, which is, okay, so if this MRD test is really important as we think it is, then I should take that information and change therapy based on that. And there's about 50 trials underway around the world that is trying to get a handle on this. And this is one of the big ones that just started for newly diagnosed patients with myeloma. They're going to be asked to get that 3-drug combination, daratumumab, lenalidomide, and dexamethasone, and be on that for 9 months, and then have MRD testing. And people will be asked to either get a 4th drug in here, that bortezomib drug, or stay on what they've been on for another 9 cycles, and then go on to the same maintenance in each arm, daratumumab and lenalidomide. So in this particular trial, both MRD positive and MRD negative people are going to be put in each group, and you aren't going to be told what your MRD status is. And this is felt, this is a study approved by the National Cancer Institute, and this is felt to be ethical, basically saying, if you are MRD negative at this point, we don't know what to do. We wouldn't tell you to stop treatment based on what we know. And we don't know if you're MRD negative, if you're going to benefit from getting an extra drug or not. In addition, if you are MRD positive at this step, we don't know if you get that extra 9 cycles of chemotherapy. Maybe you're going to be MRD negative at the end of that, and that's fine. So that's the rationale why both MRD negative and MRD positive people will be asked to be, or will be randomized to each box separately. So again, I hope that I made that a little clear in that explanation. It's a little bit confusing, and sometimes people look at this and say, well, if I'm MRD positive, of course I'd want that 4th drug, but that's not clear that that is the best thing to do based on what we know about people. Sometimes over time, their MRD negativity occurs. And this is
a schema for the study. Patients undergoing.
Oh my goodness. Okay. I'm going to have to get off this slide right away. That had a little bit of recording on it, but that was the SWOG 1803 study. I'm just going to flash that up real fast again here. And this is a study where we're asking people to have any kind of chemo, undergo an autologous stem cell transplant, and then get asked to either take Revlimid or Revlimid plus daratumumab, get treatment for 2 years, get maintenance for 2 years, and then they will be told their MRD status. This is going to be done by next generation sequencing by the clonoSEQ, meaning that they have to have that baseline sample that you can get at the beginning. And then they are going to be randomized if they are MRD positive to continue what they're on, if they're, again, in each of the arms. And then if they're negative at this point, so this is after 2 years of maintenance, then they're going to be asked to either continue or to stop treatment altogether. In other words, saying after 2 years, that MRD negative test is good enough to say, maybe we can stop treatment. So I think that's a study that everybody, I think, is pretty excited about. It's going to be completed with accrual, I think, probably in another year and a half. There are a lot of people joining this study. And this might be, really one of the biggest trials to say it's okay to stop treatment, because right now we don't know that. The future, may be that we are going to take a person, do their MRD status, and if we say you're positive, we may actually weed out those cells that are causing that MRD positive test and then profile them to say, hey, what drugs are you supposed to get? Maybe you have some different clones here that are indicating something else is up. That would be amazing if we can do that. But the questions that remain is, are we going to reach a consensus on the best method? My own opinion is I think we're going to continue to use both the clonoSEQ and and flow cytometry. I think the second thing is that should you demand an MRD test if you are a patient coming in having a bone marrow biopsy? And I think the answer to that I would give you is, I think it depends on where you are in treatment and what the next steps are that you're going to do. So for example, if you are on, let's say your myeloma has relapsed and a person is asking you to have a bone marrow test because they think you're maybe 50% better in terms of your protein levels, but you've still got an M protein that's, reasonably high and more than 0.3 or 0.4 grams per deciliter. That would be a situation where if you say, I want an MRD test on my bone marrow, with a current understanding of this, I don't think that would be particularly helpful. If you said, I've just been through a transplant and I know you're still going to tell me to do maintenance, but I kind of want to know what this is, I think that that's reasonable. Now I would caution anybody to draw conclusions to say, okay, I'm negative, I'm going to stop. One of the things that did come out in the French study that I showed you, looking at just as a group, it seems to be helpful to be MRD negative versus positive. Once the people on the transplant arm and the chemo arm stopped their maintenance after 1 year, they actually had a relapse rate as well as an MRD positivity rate that went way up. So we don't think that would be a good use of MRD testing to say after a year of maintenance, for example, that would be fine to stop at that point. I think, maybe we'll get to that point in the future, but we're not there yet. Some experts have said, if you really want to make sure that MRD test is as good as it could be, that you should also pair it with some sort of imaging to see what your myeloma is doing. So by that, I mean a PET scan or some of the fancier types of MRIs that we're doing. And some people have said, if you have that PET scan and it's completely negative as well, and you have an MRD negative test, that's a very good thing to see. Again, still, I don't know that anybody would say, okay, stop your treatment. But I think that there's getting to be some people who feel that all of the future clinical trials that are done are going to demand not just the MRD negative test on a bone marrow, but also an imaging test. I think we talked about what to do with the result, and I'm interested to see what your questions. One of the things that many people would like to see happen is that, and there is a project underway to try to achieve this, is, as many of you may or may not know, a lot of times for drug approvals, the bar is pretty high. In other words, they're looking for a demonstration of this progression-free survival being better than the alternative to which it's compared. Sometimes if it's a brand new drug or brand new mechanism, that isn't as high a bar. But some investigators have said, this MRD stuff looks pretty good. Could we just say, if we get a drug that shows improvement in MRD negativity by, say, 25 or 30 or 40%, wouldn't that be good enough to help us get an approval for a drug? So I think people think that might be in the wings. We're not there yet. The FDA has been very clear that they want to see more data before they would offer up that kind of approval for an MRD test. And finally, I think this is what everybody is hoping to see, is the blood test for MRD. And right now, this is using what's called circulating free DNA. This is basically a test where you would look for traces of myeloma DNA in blood and see if you could then make the same sort of MRD predictions we're doing on bone marrow. So instead of having that bone marrow You could have a blood test, say, run every year. Right now, the comparisons that have been done with cell-free DNA and bone marrow-based MRD is probably not as good as you would like it, but there are very smart people working on this to see that, maybe we'll get to the point that we can really just offer you a blood test. So that's the end of my slides, and why don't we move on to questions?
Thank you so much, Dr. Callander. That was fascinating, and I learned a lot, actually.
Okay, good.
So yeah, that was really great. And we have a lot of awesome questions too. Let's start with a question that I find really interesting. If someone didn't achieve MRD negativity after their stem cell transplant, what can they do to get there?
Okay, so we do have some data that says if you go on maintenance, that you actually do have a good shot at becoming MRD negative. There is, going back to that stamina trial that I mentioned, they did check MRD status in a subset of patients over time, and they were showing that people after even 18 months of maintenance were changing to MRD negative. So certainly you would go on maintenance. Some of that, for the person who asked the question in terms of what's the best maintenance, I think that would then go back to what you were told was your risk. Mm-hmm. So if a person has what we would consider maybe standard risk myeloma, that is something that's defined by low beta-2 microglobulin that should have been checked at your diagnosis, normal lactate dehydrogenase or LDH, cytogenetic studies that did not show any of the ones that we think increase risk, then something like lenalidomide maintenance would probably be appropriate based on the data. And for people who are higher risk, there are some people who even off trial would offer a 2-drug regimen. So there's some data that came out of Emory looking at this strategy using bortezomib with lenalidomide. But it is often true that you can show that people do convert to MRD negativity with more treatment.
Okay, that's hopeful. How does lab compensate for the location of the bone marrow biopsy, hip versus sternum or shoulder? So you say, go ahead.
Oh, that's a fascinating question. And for research purposes, we are kind of, I think, still married to the pelvis. 40% of your bone marrow is in your pelvis. And so the feeling is that still is a pretty good representation. It gets very tricky, though, when a person has myeloma that appears more like a bunch of what we call plasmacytoma. So that is more like tumors that are showing up in different parts of the body. And there are people out there whom, if they get a standard bone marrow biopsy, it's never shown anything. It's not even shown any plasma cells. So that's a very hard situation to know what to do with. And there are researchers who have shown that if they look at a biopsy from a plasmacytoma here, maybe versus a hip, that they can show that there's a little bit of differences, either based on the genetics, the cytogenetics, or what they call the sequencing. The big problem is we don't know what to do with that. So you could say, well, that's really interesting that happens, but does that mean that giving the whole body then one kind of treatment is a bad idea? Or are we supposed to be like sampling multiple places all the time if we can find them? And I think nobody knows that yet. But it's a very interesting question. It certainly is something that people have thought about.
Yeah, definitely.
Mm-hmm.
What is the role of consolidation therapy for someone who's standard risk MRD positive after stem cell transplant?
Okay, so there is a little bit of discussion, because some of the European trials with consolidation made it look like that was a good idea. Mm-hmm. And not so much the stamina trial that I showed you, that really did not show much effect in standard risk patients. There was perhaps a suggestion that the double transplant and high risk was a good thing to do. So I think what's going to happen is there may really be, as we get smarter about this, some people who have pretty easy to treat myeloma. By that, I mean, these tend to be people who might have on their cytogenetics trisomies. If I can use that term, that means 3 copies typically of what are called odd numbered chromosomes. So that's like 3 and 5 and 7 and 9, something like that. A person who has that characteristic and maybe a very low beta-2 microglobulin, they do look like they're going to do pretty well with lots of treatments. Like, so again, if you had VRD plus an auto transplant plus Revlimid, or excuse me, lenalidomide, probably you're going to do fine. The people who are not in that group, maybe they have some features. We're learning more about this 1Q amplification issue that may be associated with some increased risk. I think what I would tell a person, honestly, if they were thinking about consolidation, I certainly would try to do it as part of a trial. Okay. In our institution, if a person has high risk myeloma, we do believe, as do others, that it is very important for that person to become MRD negative. And so we are using more intensive post-transplant treatment. So that would be a person that we would consider doing 3 drugs with outside of a trial. And I think we're very interested in the SWOG trial I mentioned, the one that is daratumumab, lenalidomide with or without daratumumab. If they really show some advantages for that in certain subsets of myeloma, I think that's going to probably become the new standard.
Yeah, I was thinking about that too. We just had a session Monday night. I don't even know what today is.
Yeah, it's Wednesday today, I believe.
Okay. Yeah. On Darzalex Fast Pro.
Yeah.
And that, just some of the data that they were able to share there, I had that question myself is if Dara continues to prove successful in these clinical trials, when is that going to become the new standard? So that's interesting.
Well, I think, again, I think people think that's going to happen. And there was a trial that did come out from Europe that was updated called the Cassiopeia Trial, which was using a combination of bortezomib, thalidomide, and dexamethasone with or without daratumumab. And then they had another randomization to daratumumab or placebo maintenance. And, they were able to show that daratumumab maintenance versus placebo had a superior progression-free survival. But then there was a note that for those people who got daratumumab as part of their initial treatment, it did not necessarily make a big difference for them to get it as maintenance. Now, the issue is that in that particular trial, the daratumumab wasn't given indefinitely, or, I believe the cutoff was at 2 years, I think, or it's 18 months. So, whether, and the other issue that came up, maybe if you change the upfront combination. So I think those are the kind of questions we don't know. Maybe if you do get daratumumab as part of your initial treatment, adding it in on the back end isn't going to make much of a difference, but I don't think we know that yet. Okay.
Thank you for sharing that. I think this just proves a testament to clinical trials and how important they are in accelerating myeloma research.
Yep.
It's so important. We do have some myeloma patients who are relatively new, and one of them is asking, why do you think he doesn't have an M spike? So do you want to talk about that?
So that may be for a couple of reasons. So the antibody molecule, the structure, it looks like a Y with 2 pieces stuck to each part of the Y. So the big part of the Y is called the heavy chain, and the smaller parts are light chains. And about 80% of people with myeloma will have cells that produce heavy chains, and that's what you need to make an M spike. You need some sort of heavy chain. But 20% of the time, a person's myeloma only makes light chains. So it's possible that you are in that group where how your myeloma is going to be followed, they're going to be measuring kappa and lambda rather than something like IgG or IgA to tell you how you're doing. There is a tiny percentage of patients who don't make much protein at all. And those people are hard to follow. They might be somebody in whom your doctor would say, we're going to have to do bone marrows kind of frequently or PET scans, but that's pretty rare. And most of the time, somebody will make enough light chains that you can get some information out of that as to how they're doing.
Awesome. Thank you. Joe says, if MRD is rising again after MRD negativity status, at what point would you consider it a formal relapse and start new treatment?
Oh boy, what a great question that one is too. Really good. Okay, so right now, for a lot of clinical trials, there is a bar that the International Myeloma Working Group established saying relapse means you have a monoclonal protein that has reappeared that is more than 0.5 grams per deciliter, or you have light chains that are now more than 10 milligrams per deciliter or 100 milligrams per liter, or you have a new plasmacytoma, or you now have 10% plasma cells in your bone marrow. So for that person who has, like, maybe your light chains were 0 and now they're 5, or they wouldn't, I'm sorry, they wouldn't be 0. Maybe they were 1 and now they're 5, or, you know, there's a big controversy over whether that should be considered a relapse and whether we should retool all our studies. And there's a proposal underway to say, you know, too bad, that's not 10, but I don't like that 5, and maybe I should be on treatment. And I think you're going to see the same thing with MRD. Now, MRD, because of some of the things I said about the difficulties you can run into testing it, I think a lot of people right now would not say you're going on treatment because you're MRD positive. They would probably test it again. And I think the only exception that would just come to mind is if you were known to have high risk multiple myeloma and somebody is using that as a following, that might be a trigger. They'd say, I'm sorry, I'm going to put you back on treatment. But I think for the vast majority of people with their myeloma, I probably wouldn't use one MRD turning positive test to say, okay, now you're back on treatment.
Okay, that's a good answer. Thank you. Sarah is wondering, how does progression-free survival look for younger patients, for example, 40s with no maintenance after transplant?
So in general, if you're looking just at progression-free survival, it's better if you're younger. High-risk myeloma still stands out as always having a harder time regardless of age. But the issue ends up being, as you can imagine, assuming that you were in that age group, you know, we're not so much worried maybe about the first 10 years now because we think we're going to have reasonable treatments. What we're talking about is what about the next 10 years and the 10 years after that? And can we tell you at age 40 that we think we're going to be able to restore you back to a normal lifespan as if you didn't have myeloma? Certainly that's the goal. So I think, you know, as a group, people who are younger do better, have better survival and have better PFS in all the trials. But then the question is, yeah, I don't want 3 years of PFS. I want 30 years of PFS. Yeah, exactly. And so that's what I think people are very acutely aware of that and are trying to work on making, you know, each time you get treated, that control of your myeloma being as long as it possibly can be.
She follows up with the question, it's her husband she's talking about, can he still get to MRD negativity without maintenance?
Yeah, so there are people, so myeloma cells, you know, we knew years ago before we even had maintenance that you could do an autologous transplant for somebody and they would end up at the end with a measurable M protein. We wouldn't give them anything because we didn't really have anything to give them, but it would disappear over time. And as I mentioned in that Stamina trial, we did see that people, you know, even people who had stopped their maintenance, for example, their MRD went to negative. So it's possible. I think.
And is that, sorry to interrupt, is that half-lives of the medicine or what is it that's allowing?
Well, I think it's more, I think that, you know, myeloma cells tend to be relatively long-lived. And so I think that the feeling, so that's a great question, Audrey. So, you know, there are different theories. So some people feel like, okay, those myeloma cells were hit by the melphalan, for example, from the transplant, and it's taking a while for them to plots. You know, but the other thing may go back to that graph that I showed at the very beginning, saying if you get below a certain level for your myeloma, your immune system may be able now to control it and say you're gone.
Okay. Interesting. That's fascinating. Okay, I'm going to try to cruise through some questions because we're limited on time, but I want to get to as many questions as possible. So Diana is asking, is the progression-free survival data included in the MRD report?
It usually isn't. That PFS data that I showed you is basically all coming from trials, and it would be impossible to have you seated in front of somebody in the office to say, okay, I know what your PFS is right now. So basically what we can tell any individual is, here's the, like I said, the median, and here's roughly the average PFS that you should expect to get from this trial, or excuse me, from this treatment. But unfortunately, we know that half the people are not going to do as well as that, and half people are going to do better than that. And so for any individual, it's really hard to say, this is what your PFS is going to be.
Okay, thank you. Can we use MRD testing to predict possible relapse before blood work changes?
Well, at least right now, that doesn't tend to happen unless you were having somebody's doing a bone marrow biopsy on you like every month. I think usually it's more the other way around, at least with our current testing, is that what will happen is somebody will see a flicker of protein in the blood show up, and that might trigger doing a bone marrow biopsy. It would be a very unusual situation where, and maybe it would be for a trial, for example, that somebody would have an MRD test come back positive, even though they're otherwise fine. And that, I think, would maybe trigger the situation that we talked about a little bit earlier. I don't know that I would necessarily tell somebody, okay, we're going to do, we're going to start you on treatment now. Those tests, both the flow cytometry test and the NGS test, have some data, including that refers to how much they're finding. In other words, whether it's just a tiny bit of myeloma or whether it's a ton. And, that could be something that you might use to say, okay, I'm really worried about this. I think, you need another treatment right now. Most of the time, if you're finding by either methodology that somebody's got a lot of detectable MRD, they often have something by light microscopy, like when you're looking under the microscope at the bone marrow, you can pick up something that's abnormal. So that's a pretty long-winded way to answer that question.
No, it's okay. I appreciate it. Thank you. How can somebody be in complete response but still have minimal residual disease?
Aha, well, that's because we think that, again, those cells may end up being sort of dormant, and they're not making M protein or light chains in very large amounts that you can pick it up in blood, but they can be just sort of nestled in that bone marrow, and you're picking them up that way, even though it looks like you're in complete remission.
Awesome, thank you. Can a 3-drug combination retire the stem cell transplant? I know this is another controversial question.
I'll tell you, one of the things that there is this study that has gone on called the E1A11 trial, and that was looking at bortezomib, lenalidomide, and dexamethasone versus carfilzomib, lenalidomide, and dexamethasone as initial treatment, and they without a transplant, and they showed in both of those groups that the progression-free survival at about 3 years was around 85%, which is pretty good. I mean, that matches some of the transplant trials. Now, that's using maintenance as well. So whether that data holds up, and part of the reason that other trial I showed you is using daratumumab with lenalidomide and dexamethasone for people who want to defer a transplant, is there's some people who think that's going to turn out to be as good. So I think based on some of the other data I showed you, like that Forte data suggesting that transplant does add something to MRD negativity, certainly I think a lot of people in the field still are very much pro-transplant. I feel like I'm kind of waiting to see if we can get to the point where we would say, no transplant, or transplant deferred until something happens. And again, this is a whole nother can of worms, whether we start to have more data that says, hey, you're not going to get an autologous stem cell transplant, you're going to get a CAR T transplant instead at the time of your first relapse. Awesome,
thank you. What number is considered low levels of MRD? I think that's a good question.
Yeah, so the initial investigations were looking at less than 10 to the -4th. So what'll happen is, if you read these reports, they will say something like that and say, okay, we see sometimes in a flow report, they'll mention events, meaning how many times they can find a cell. So if you're looking at, most of the labs are running probably looking for less than 1 in 100,000. clonoSEQ has a sensitivity more like closer to 1 and maybe 10 to the -6, 1 in a million. They will then report out something that's either no detection at all, if that's negative, or they'll say this many copies of the clone were detected. And of course, the higher that amount, the more they can pick up, the more that might mean that people think that there may be some suggestion that if that number is very high, that could mean that your chance of relapse is very, very much imminent. So, but they are a little bit semi-quantitative.
Okay, awesome. We have quite a few questions left. I'm just going to filter out a couple just because we're running low on time. I apologize if we don't get to your question. How does CAR T affect the MRD status? What have we seen in the CAR T trial?
So interestingly, that the response rates to CAR T are very quick in most of the studies. So you can start to see people who enter a complete remission in 30 days, certainly by 90 days, many times. And the MRD rate also looks pretty high. The question is that durability? And meaning like, does it last? And it does look like in the CAR T trials for myeloma that have been published, if they have done MRD testing, those people who are MRD negative seem to stay in remission longer. I don't know that we have like an exact equation that you could say, okay, if you're MRD negative, those patients have stayed in remission upwards of 2+ years if they've had long enough follow-up. But I don't know that anybody has gone farther than that to say, oh yeah, that means they're never going to relapse. But I think like everything else we know, it also looks like a good thing to be MRD negative as well after a CAR T.
Awesome. Okay, one more question and then we'll finish up. And for those that didn't get their questions answered, we will host this every other month and you'll be able to come with your questions and continue to ask. Paul is high risk and he's had several clonoSEQ tests, several bone marrow biopsies. He hasn't been able to achieve a remission pretty much or stable disease ever. But he's wondering right now, he's on Blenrep. Is that better? And I guess this can be asked more in a more general sense. Is that better? Is finding a new treatment to attack it, is that better than trying to just go on a maintenance combination?
Well, I think if Paul, if you've had that difficulty and you're now on a treatment that is producing MRD negativity, which it sounds like it is, you said, I think below level of detection, that's great. And I don't, we were fortunate to work with belantamab here for one of the original trials, and some of our subjects had just fantastic responses to this, very long responses. And I think if you've just the suggestion being that it's been hard to get to a drug that has produced that, then I would say that's great. And I'm not sure that I would be in a big hurry to stop that unless you are having a lot of trouble with keratopathy. Most of our patients on trials, if they delayed doses, the keratopathy improved. If you're off a trial, some people think the strategy may be to lengthen the treatment interval a little bit, say from 3 weeks to 4 to even 6. If you're not on a trial, that is something that you could consider doing if you're having some trouble with keratopathy. But it sounds like you're having a very good response to that. I think just to try to be a little bit more complete for this situation, what we don't really know is how are you going to do after belantamab if you want to go on to another BCMA targeted therapy. It looks like some people probably will still respond, but we're just sort of trying to get some more real world data about that to see what's going to happen.
Awesome. Thank you. And thank you so much for your presentation, for answering those questions, Dr. Callander. We really appreciate your time. I'm going to close out with just a couple of announcements and then we will be done for today. So our next meeting is going to be in October. This group is going to meet every other month. We're going to be discussing the MRD testing with the clonoSEQ test. So we've talked about it a little today, but we're going to have talk more about the Adaptive Biotechnologies MRD test, which is called clonoSEQ. With this test, doctors can help you monitor your cancer, manage decisions, and move forward with confidence. So we're still confirming a speaker and a date, but we will make sure to keep you updated and just keep your eyes out for our next MRD chapter meeting in October. Because we're running low on time, I won't go through every single one of these. We do have one tomorrow, the Myeloma Caregiver chapter. We're going to be talking about how to advocate for you and your loved one in cancer. Author Raina Weiner wrote a book called Trust Your Doctor, but not that much. No offense, Dr. Callander. And the idea is we need to become advocates for ourselves and really understand and educate ourselves about the disease, whether we're a caregiver or a patient, and be able to work with the doctor in finding the best treatment for us.
Absolutely a team. That's great.
Thank you. The other events are listed, and the link to sign up for any of those events, as well as events that I haven't mentioned, is found at the bottom of that slide and will be included in our follow-up email. A thank you to our sponsors again: Bristol Myers Squibb, Amgen Oncology, Genentech, Adaptive Biotechnologies, Sanofi Oncopeptides, Karyopharm Therapeutics, and Takeda Oncology. And thank you to each of you for joining us for the launch of this minimal residual disease chapter. We appreciate you and hope that you have a great rest of your day. And thank you again, Dr. Callander.
My pleasure. Thanks. Everybody have a good evening.
You too.